All right, so Leonard said this morning that the definition of a good chair is to start on time and end early. Well, I've just blown that since we're 2 minutes late. But welcome back to this afternoon. I think your colleagues on the third floor and in room 105 will soon join the rest of you who got the message to be back at 12:45. And thank you for coming back. I think we had 2 wonderful sessions this morning, and we've got 3 more planned for you this afternoon, and look forward to the ongoing discussion. I have just a couple of announcements. First of all, I do want to note that not only will the video of this be archived, but you will have access to all the slide presentations on the Academy website. That can be found on that notes page. So afterwards, you will be able to get the slides. The other thing that I wanted to mention that, as we said first thing this morning, there's plenty of time built in for discussion. Just so that you all are aware, discussion includes telling your own stories. It doesn't have to be getting up to ask a question. So feel free to come up and also share your own experiences in terms of what the panel members are talking about. And last, the session right before lunch definitely had some focus on that 4th aim in terms of workforce. And I wanted to share with you from the Academy staff, wanted you to be aware there has been a group assembled. They had their first meeting back in January. The National Academies has a focus on the workforce and looking at resilience and stress. And they're just beginning their work. They are not a roundtable, so they're not as constrained by roundtable kind of rules. It's a looser structure, but it's predominantly nursing and physician organizations that are at that table. So stay tuned, because there will be work coming out of that group. So I am now going to turn it over to Judy Perez.
Thank you, Brenda. Thank you. And as Brenda said, we've had a really exciting morning, and we're starting to learn more and more about all the various models and efforts that are being put into community-based palliative care. I come to palliative care from 2 distinct disciplines that really do always put the person first. First is clinical social work, which the first thing we learn in social work school is begin where the person is, and long-term care, which I still like to call long-term care, which is also talking about the person and the family. What I'm excited about especially, though, is that that's all been discovered. Within the last year, major organizations have come and started to look at what are the needs and how do we serve people with serious illness, whether it's the Bipartisan Policy Center, CAPSI, some of the major foundations that have gotten together for funding, and Medicaring. So with that in mind, today's panel this afternoon is going to start us out with some real serious innovators, people who have been at the forefront of this in terms of delivering person-centered care for quite some time. And so I'm excited to introduce and do want to recommend that you look at your program for the larger bios, but we will be hearing, and I'll say in order, and then we're holding the questions till the end. Hearing about providing care for patients at home through the Independence at Home demo projects by Dr. Eric DeYoung, then reaching patients in rural and underserved areas, which is something that is really on the forefront by Dr. Michael Franken, and then serving the dual eligible population, which is really one of the populations that is key to needing these services by Dr. John Loughnane. And then finally, transforming the care delivery, which is what everybody in this room is about and trying to do, by Dr. Michael Lee. So with that, let's first hear from Dr. Eric DeYoung.
There we go. Good afternoon, everybody. I'm just going to tell a little bit of my story briefly, just so you know who I am and my background, and then I'm going to walk through our model of care. So I'm Eric DeYoung. I'm a primary care geriatrician. Kind of was raised in Chicago and then kind of bounced around the country and landed in Baltimore about 22 years ago or so. And in my residency, as a second-year resident, I was handed a panel of 10 patients who lived in Highlandtown and Dundalk, Baltimore. And my boss at that time, Dr. John Burton, said, "You're their house call doctor. You have to go out and take care of them." So that's kind of where I started learning about the value of taking care of people in their home. And so I'm going to fast forward a little bit and kind of talk about a model that we've been doing in kind of DC for 18 years, and I loved actually Diane and Brenda's charge to have us go away from this thinking this can happen. You can change a system, and you can kind of really do this. And at least as of now, I'm at least a surviving example that you can do this. And for 18 years, we've been working on this model, and still it's a work in progress. So home-based primary care is the clinical model, but more importantly, it's a focus on patients who have very serious illness, who have functional disability, often have been high cost in recent years, and have trouble getting out of the house to see a doctor. So is there to forward the slides? Do I use this? All right. So these are the 3 take-home messages that I'm going to leave you with at the beginning and hopefully at the end as well. Home-based primary care is a team approach that implements palliative care principles as a major part of its work over time, the course of a patient's life and illness, and across all settings. That's kind of our driving mission, is to take care of the most seriously ill 24/7 over time and until the last day of life. It has relatively proven value, especially in the last few years. A number of good results have come out showing the patient experience and lower per capita costs, and we'll touch on that. And then the policy change that it really is helping to sustain the model now and could sustain it nationwide. One example of policy change is the Independence at Home demo, which we'll talk about. And there's actually a bipartisan bill that was just introduced last month. It's S6464 if you want to ask your senators to co-sponsor, and we're working on that as we speak. So I'm going to talk about a patient first. This is a typical patient, although she's a little younger than most of my patients. I actually have average age in the 80s and 90s, and the oldest lady actually in DC is in our practice. She's 113 and a half. She's the 3rd oldest in the country. But this is a 72-year-old who represents a lot of the same issues. So she had liver and heart failure when we met her, depression, frequent falls, and a lot of caregiver burden. Before she came from Colorado, she had 6 admissions in the year that she was living there. And that's 6 admissions per patient year for the health economic measure. Her daughter moved her to our zip codes, actually, on the east side of DC, so she could enter our program, so she could get home-based primary care. Over the last 5 years, she got about 200 urgent and routine house calls, including social work services, as well as NP, MD, and kind of a lot of other services. You can do mobile x-rays, EKGs, echoes, labs. This all can be done in the home on a mobile basis, and she received that over 5 years, including a mobile electronic health record with wireless connection securely to the hospital system. In 2014, she had a major GI bleed from her esophagus and almost died, and she was in the ICU, and they did this TIPS procedure, which stopped the bleeding, and she actually went home from the ICU, actually within 48 hours, which was surprising, but it happened. And then in 2016, she started having respiratory failure, and we had a joint visit at home between myself and our NP and the hospice team, and we transitioned her to inpatient hospice, where she passed away within about 10 days. So she had 3 admissions in 5 years in this model of care. That's an N of 1. It's not a large study, but this is pretty typical for before and after when people are either in the VA home-based primary care program or freestanding kind of programs like this. She had about 0.6 admissions per patient year. Greater than 99% of her days were spent at home, which I think is a kind of rising metric that we're using. Days spent at home, I think, is a very valuable metric, and about 5 years with her family. This is the clinical model. It's a picture with the patient and family really at the center where they live. The team is a 24/7 MD, NP, social work team that provides phone access 24/7 and then commits to coordinating all the things in these other circles. It's about 14 or 15 different services. Again, it depends on the need of the patient and the family at that moment in time, at that stage of their illness. But we end up tapping into essentially all of these over the course of the patient's life. And I'm glad to take more questions. Obviously, there's a lot of detail about how do you integrate this, how do you actually activate these services as you go forward taking care of people. Actually, I'm going to go back one. I don't know if I can. It's okay. So I was reading a little bit about the palliative care principles before coming to the talk and preparing this, and this is from the up-to-date summary that Diane, I think, and a colleague authored for up-to-date. The 5 principles on the left are the major principles of palliative care: treating symptoms and suffering, establishing clear goals of care, close communication, psychosocial support, and coordination. And this essentially is what we would want for all of our loved ones who have serious illness. And the home-based primary care approach essentially tries to meet all of these principles using a primary care house call team that's very skilled in managing serious illness and managing all the symptoms and suffering. The MD, NPs, and social workers all take turns actually establishing goals of care depending on the problem the patient and the family are facing, but it's really based on a continuity of relationship. I want to highlight that. I think kind of the key linchpin, at least in our population, that we find is the continuity of relationship of a primary team over time and across setting has a powerful effect on being able to establish and meet the goals of care. The close communication is really executed by the interdisciplinary visits in the home, as well as, again, 24/7 phone access. We see our patients about every 1 to 8 weeks, depending on how seriously ill people are. Psychosocial support, we have course social work staff, and then we coordinate that picture I showed you. All those services are coordinated by the team, the immediate primary care team, over the course of the patient's illness. The only distinction or kind of thing I would mention is that this primary care team is not a consultative or specialty service. It's really primary care that tries to execute all of the palliative care principles that are outlined in our field. So what are the strengths? Just briefly, I think the many visits in the home really have a transformative effect on listening and learning to the patient and the family and understanding their needs and their goals. And it builds trust, because when things are hard, when people are dying or you're not sure if they're dying and you're trying to decide what to do in terms of level of care, if you have trust with the family, it allows you to navigate that situation. A couple other strengths, I think having one primary care team with relationship over time that's interdisciplinary, that's available and can make visits. And it says mobile her, that's a typo. It always automatically changes EHR to her. And we do have actually a lot of mobile hers, actually, because our practice, for whatever it's worth, and I'm trying to get the men out there to kind of wake up, our practice has 29 staff, and we have 3 men. There's 26 women and 3 men, so we do have a lot of mobile hers. We coordinate all the services, including acute care, and I would just raise this as a provocative question that I think the hospital care is often divorced from outpatient care, and I think that's a real problem. I think we have committed since 1999 that we're going to take care of our patients in the hospital as well as at home. And so we manage those transitions in and out of the hospital with the same team that knows the patient and the family. And I think that's really powerful for the patient and family, but it also affects metrics like costs of care, which we'll touch on. So independence at home, what is it? It's really a Medicare demo that was passed as part of the Affordable Care Act, allowing up to 10,000 patients. It started in 2012 for implementation for ill, disabled elders with persistent high cost. And they're defined in the language of the statute as 2 or more chronic permanent illnesses, have to have a hospital admission and post-acute services, meaning high cost history, and functional deficits. It's paid on a shared savings model. So we get paid within Medicare fee-for-service, but we also will get shared savings if we meet 6 major quality metrics, and then if we reduce total cost per capita. And that's the actual costs of your patients, your population, compared to expected costs. And there's a long conversation. How do you decide what expected costs are? We can talk about that, but Medicare and CMS have figured out some formula for how to try to calculate expected costs, and that's still can be a work in progress. And you get savings only after you've reduced the cost by 5%. So you don't get a dime unless you've reduced total cost by 5%, and then you can keep 80% of the other savings after the first 5%. If you meet all 6 quality metrics. If you meet 3 or 4 or 5 quality metrics, you get a chunk. You get like half of that as opposed to the full amount. It can make home-based primary care scalable if you achieve those quality and savings. I'm going to highlight a couple other results that have come out in the last 3 years, really. The VA home-based primary care model has had the highest satisfaction of any VA program. It's reduced total costs by 12%. That's VA costs and Medicare costs. A study here in DC at Medstar Health where we found that mortality, interestingly, was similar of 722 cases, 2,100 controls. The mortality was the same in both groups, but the costs were about 17% less. And in the IEH demo in years 1 and 2 thus far, which have been reported, and if you'll notice, it's 11,000 patients, so it's oversubscribed. This demo is one of the more popular demos, and the patients and families have really been very open to being in it. And 9 of 15 programs were actually paid savings. And in years 1 and 2, it saved the government $32 million, but $16 million of that went back to providers. This is just a visual. On the left, it's the DC-based study showing the annual cost decrease from 38,000 down to 29,000. This is on the most sick subgroup of our house call population. And then the IEH numbers on the left, an average cost of 60,000 expected per year, 60,000 Medicare dollars per year, dropped to 48. So it's still expensive, but there's a lot of money that can be saved in this population. So what are the challenges? Funds for time is really what it comes down to for us in terms of having the time for travel, time for family meetings, all the discussions that are indirect, the coordination of all those 15 services that I talked about. Having funds for the time to do that is one of our major challenges. Attracting docs and workforce is connected to that. Because if you don't have the funds to kind of have new capital and to pay people, say, competitively with hospitalists or other even primary care jobs, it's hard to attract the docs. And finally, training on best practices. There's a wide range of house call programs around the country in caring for folks in the home. And I just want to mention there's something called the Home Center Care Institute, which is putting together a best practice curriculum for training new house call programs. And this is my last slide. The keys to success are really building these teams as best we can around the country, finding the right staff with the attitude and compassion to do the work. I've been struggling lately with recruitment based on lifestyle and compensation concerns from kind of younger doctors who have significantly different expectations, I find, than the old-fashioned doctors. The efficient and high-quality daily operations is crucial because if you're not efficient and really don't produce the high-quality service, you don't get the referrals and you don't get the word of mouth to grow the program. And the diverse sources of revenue is really crucial because you can't depend just on fee-for-service. You really need, we have like 4 or 5 different buckets of revenues which we can talk about, but having diversity of revenue is crucial because if one kind of dries up or a healthcare reform gets repealed and replaced, you have to have something else to try to take its place. So the IH Act is S464. That's my policy kind of tidbit to close with. There's a website, iehnow.org, which you can go to learn all about that act. And if you want to, contact your senator or House member to co-sponsor it. And this is our team. So finding these people and having them happy and working in a dedicated way is really the key to making the difference. I can't highlight any individual, but I want to mention the NPs are a crucial role on the team. They're out today in the DC making urgent house calls, preventing ER visits, and keeping people kind of as stable as they can at home. And I think questions we will save for later. Thank you.
Thank you very much.